It's 4:01 and I see that the number of participants continues to increase. So we'll give that just a couple of more minutes and then we'll get started here shortly. Well, it's 4:03, and as to make the most of our time for our guests who are here to share their knowledge and information, we'll go ahead and get started with this webinar. I would just like to start us out by saying good afternoon and welcome. I'm Dan Gregory. I'm one of the assistant superintendents here in the Peninsula School District, joined today by my colleague, John Hellwich. John, if you want to give a quick wave, and then Sara Hoover, our risk manager, is here as well to share her knowledge and information as well. So as the numbers continue to go up, over just 150 participants in the webinar, we know some of you we thank you for being here and being on. We know there'll be a few others that are trickling in as we go forward. But again, we just wanted to start by welcoming everyone, acknowledging that this is a webinar that's open to both Peninsula School District staff as well as parents and community. It's been advertised for the purpose of having people join us to learn more about the work we're doing as a district with Tacoma-Pierce County Health Department. As we get started, and I'll turn it over to John here in just a minute, I just want to take a moment to acknowledge the Peninsula School District COVID-19 testing pilot task force. And that's a mouthful, but about a month ago, we gathered a group of nearly 25 Peninsula School District staff members and parents, and the staff members included teachers, classified staff members, bus drivers, custodians, as well as building principals and administrators. And again, that group was joined by a number of parents. And the goal was to look at COVID-19 testing and how it might be implemented in the Peninsula School District to test students and staff on campus with the goal of using the results to help isolate positive cases quickly and to quarantine close contacts to prevent disease spread amongst the school population and beyond. And that's somewhat similar to what you might have been witnessing with sports teams and other organizations as they continue to try to continue operations as normally as possible during the pandemic. We do want to take a moment to honor the work the task force has done, as they've done a great job in terms of generating questions that we've submitted to the health department, but they've also helped us identify the best ways to get information to our valued staff and to our community. The webinar today is one way the task force recommended as an effective way to communicate information to our staff, to our parents, and to any students who are watching, as well as to our community. So again, we just want to honor the work of that task force. We appreciate their involvement. They've been a great guiding group to help us as we've moved forward through this. I'll turn it over to John Hellwich now to talk a little bit more as we lay the foundation for today's meeting.
Yeah, so just to preview the purpose for the meeting today, it's to host a live discussion with Dr. Anthony Chen. We are fortunate to have. He's the Director of Health at the Tacoma-Pierce County Health Department, and to answer questions that have been submitted by our staff and our community. We want all of our students and staff back in schools as soon as it's safely possible to do so, and we're fortunate to be selected as one of the few districts in Pierce County identified for this testing pilot. So to give a little overview of the events that are coming up associated with the pilot. So we have this discussion tonight. The next one would be on Sunday, this coming Sunday, the 29th. We have opportunity for staff, students, and community to receive a PCR test. That's the common test, for lack of a better term, the non-rapid test. that you would normally get if you went in for a test. And the mobile unit for those tests will be at KPMS, Key Peninsula Middle School, and Gig Harbor High School between 10 a.m. and 3 p.m. this coming Sunday. Then next, starting on Monday the 30th, the week of the 30th, we'll begin our in-school rapid antigen testing program, starting with a few schools on Monday and then moving throughout the week. Before I turn it back over to Dan to introduce Dr. Chen, I want to acknowledge that we received a large response in our request for questions. Some of the questions are specific to staff, some are specific to students, some to families. So what we tried to do is isolate the questions that were most pertinent to everybody. So we'll be sending more information out to staff and to our community regarding more specifics like the dates and times for the testing at each site, links to consent forms, etc. Okay, Dan.
Thank you, John. And again, for this afternoon's webinar, we're going to give the floor to Dr. Chen and his staff here shortly. They will present. They were provided some of those questions ahead of time, and so they may address some of those questions as well. And then if time permits, we'll kind of continue down the question list and see if there's time to answer a few more questions. That being said, I have the pleasure of introducing Dr. Chen. Dr. Anthony Chen, as John said earlier, is the director of the Tacoma-Pierce County Health Department. He brings a great deal of expertise to the position, including serving on state and national public health committees, regional planning bodies, and local, state, and congressional district committees on healthcare access and reform. Dr. Chen is a graduate of Duke University Medical School and completed his residency in family medicine at the University of Cincinnati. He received his Master's of Public Health at Harvard School of Public Health and is taught at medical centers and university. Dr. Chen, we're fortunate to have you here with us this afternoon. Welcome. And if you would, please start by introducing your staff and then go right into the presentation and we will get out of your way for a while.
That'd be great. Thank you, Dan. And I appreciate everyone who's online. I know you have a lot of questions. We'll try and get through our presentation quickly so that we can get to your questions. I have two of my staff with me today, Dale Phelps. Dale, if you could wave. Dale, it does our communications for COVID-19. And Jennifer Thompson. Jennifer, if you could wave. Jennifer is one of the project managers and one of the movers behind this testing program. We have several other people, Morgan Black and Lori Carnes, who some of you may have worked with in other contexts, but they could not join us today, but they're valuable members of our team. So with that, I'm going to go ahead and I don't see where I can share my screen. Oh, here we go. I'm sorry. It's one of the challenges of jumping between too many different platforms that we have to use. Here we go. Is that showing up okay for you all? We have the title slide, great. So with that, I'm just going to move ahead. We've just covered our introductions. I think you've heard a little bit about why we would want to test children and teachers for COVID-19. You've also heard from Dan and John on the plan that's going on and the timeline and process in your district. And of course, we'll make sure we have time for questions. You heard us mention earlier about, if anyone has kids or friends, with kids in college, many colleges are doing testing of some form. The reason that the Seahawks have been playing and the sports teams have been playing is because they've been testing. And the idea there is to try to use regular testing to identify positive cases and safely isolate them, and also to quarantine people who've been in contact with them to minimize further disease spread. And we are seeing this as a great opportunity to bring this, this approach to our schools. We know that other schools and the Department of Health are working on a similar approach, which is probably going to kick off at the beginning of next year. We have been working with Department of Health. They've been very helpful for us, helping us look at different models And basically, the 3 school districts here in Pierce County are going to get a head start on this. The Department of Health is very interested to see how this is going. We are very interested in both, as you'll hear later, both in terms of the logistics of how this might work, as well as what we might find with the testing. And as I mentioned, the testing pilot has been developed with guidance from the Department of Health. So again, one of, especially when we don't have a cure and we don't have a vaccine for COVID-19, is so important for us to use tools out of our public health toolkit. And one of those is making sure that we are identifying cases, identifying their contacts, getting the cases isolated quickly, quarantining their close contacts. And this is a critical strategy for the COVID-19 response right now. And in order to find positive cases, we need to do testing. One of the challenges with children is that children tend not to show a whole lot of symptoms. And so this is kind of part of this, a lot of understanding that we are gaining about COVID-19. Children don't tend to seem to get as sick. They don't show as many symptoms. Oftentimes they are asymptomatic. They also tend not to spread it as much. However, this increases with age, so that certainly by middle school and high school, children are behaving like adults in terms of how sick they get, how much they're transmitting disease, and so on. So we looked at different models, and everything. Some of the sports teams and colleges are testing twice a week. New York was testing every 2 weeks, and we felt that doing a weekly testing model was going to work the best for us. And it turns out that when you look at the behaviors on these tests, this is actually a really good timing for us to do the testing. So I kind of gave you the high level about why we want to do it, but also let's come back and talk about some of the things that people in our community have been talking a lot about, that there's a lot of concerns right now about the fact that children have not really been in in-person education since the spring. So parents and educators are concerned about the educational, social, and emotional needs of our children. Learning does not work as well remotely as in person, and is especially challenging for the youngest learners and those with special needs. At the same time, we've heard from staff and parents that they're concerned about the health and safety of their children. Children and the staff, of course. And, I think all of us have either heard through the news or known someone that we've read about through social media, or just personally have talked to who has become sick with COVID. This has actually been a really interesting disease in terms of what it's showing us. It can create some really unusual complications among children. For example, it creates a very rare but serious immune response, similar to something that's known as Kawasaki's disease. And then for all ages, especially as you get older, they can get very unusual blood clotting disorders that can lead to fatal outcomes or amputations or severe implications. So certainly people are warranted in their concerns. So even though the majority of people have mild illness, it's also been reported that many people will have lingering symptoms for a long time. And of course, those with chronic illnesses and are of older ages are much more likely to develop complications and die. Another concern, of course, is the public health concern that now we are in this huge surge. We're not seeing an end to it. Today, we hit another record number of cases here in the county. Cases are accelerating everywhere in Washington as well across the country. And of course, public health is concerned about being able to test quickly, identifying those who are positive, and preventing disease spread in the community. So our goals in doing the testing pilot is students' physical, mental, and emotional health, the safety of staff and students for a safe in-person learning environment, reduce transmission to community, and increase access to testing in areas with fewer testing options. We really, when we started thinking about doing this testing pilot, if you remember, I talked about those 3 kind of areas of concern. we really saw this as a way for us to reach some kind of win-win-win, that a lot of the decisions we're making now are empiric. As I mentioned to you earlier, we think that children get less sick. We think that they spread it less. At the same time, how do we balance that against the concerns of people who are very worried about safety and health? And we thought this was a good way where we could address all three of those concerns and still move forward. So here's our plan. We're going to be educating the public about the importance of testing. We're going to be doing testing of the school community before. Here it says before in-person learning. Peninsula School District already has some in-person learning. It's basically kind of moving forward in our program. Students and staff will receive a COVID-19 test once a week. This will allow us to quickly identify and isolate any positive cases and quarantine their close contacts. Of course, we will be checking results to monitor the progress of the program, and we will be evaluating at every step that we move along. This program will then close when the school breaks for holiday break, and we will sit down and do a deeper analysis and see how it's going and how we would move forward with it. Just to let you know, when we conceived of this program, we used the equity lens. We wanted to prioritize the smaller, more rural school districts because access to testing is much more limited in those school districts. So the three participating school districts are White River School District, Eatonville School District, and then your school district, Peninsula. You're working with the Tacoma-Pierce County Health Department, and also the Pierce County Department of Emergency Management is a critical partner in this work. So just to give you an idea of what to expect for the parents who are in the audience, when the student arrives at school, as usual, they'll be screened for symptoms of COVID-19. Assuming that they are negative in the screen, they will go to class and begin their instruction. When the class is ready to be called up for testing, the teacher will receive an alert. The teacher will confirm that students have consent forms. The teacher will then walk students to the testing site and instruct students to line up outside, physically distant. The student then will check in with registration. They'll confirm the name, date of birth, very much like if you went to see a doctor, they want to make sure they're doing the right thing on the right person. There will be someone we're calling a swabber because they're swabbing the nose. They will confirm the student's name, date of birth, ask for verbal consent, and then they'll perform the swab. The student will walk to the exit where the navigator helps them back to their class. And I'm just going to show you next the schematic of what these flow would look like. You can see in the lower left, students will come in to the area. There'll be multiple stations for the registration. They will get swabbed. The students will exit to the upper left. And then the swab station, the person doing the swabbing will actually hand it over to the processor who will run the test. And the test that we're using for this is a 15-minute antigen rapid point of care test. And we can discuss the details of that test later. Well, actually, normally, Jennifer, normally Lori will demonstrate what this looks like. Do you happen to have one of the test kits, Jennifer?
No, I think they're all at our testing site right now.
Okay, all right.
Wrapping up at another testing site.
Okay, so just give you a very high-level idea of what it is. It's basically like a swab, a Q-tip. You may have seen some pictures where they do the PCR testing, like in a drive-up testing, where they use a skinny swab. It goes way in the back of all the way back in the nose, so it touches the back of the throat. This is not that type of test. This is just a swab. It goes a little bit, half an inch into the nose. It just gets twirled around. They twirl it in both nostrils just to make sure they get a good specimen. And then the test is, the swab is inserted into this kind of card with the reagents embedded in it. And then there's some chemicals added to it. Many people compare it like to a pregnancy test where there are colored lines that show up that tell you whether it's a negative or positive test. And this turns positive in 15 minutes, or we will have a result in 15 minutes. So here again is the timeline that we will be working on You can see today, the 24th, we're doing the presentation. Mobile testing day will be on the 29th, and on that day, emergency management will be there. Parents can participate, and then the school-based testing program will start on the 30th. And then, as I mentioned, the pilot ends at the holiday break, and we will evaluate the pilot and work with the school district on next steps for January. So with that, that's the end of my presentation. We will now transition to questions, and I'm going to stop sharing. And Dan or John, is one of you going to be reading the questions?
Yeah, we'll probably share that duty, Dr. Chen, because
Okay.
as John mentioned earlier, there were quite a few, and really we've categorized them into themes. And so the first theme is really around, and you touched on this a little bit, but the details of the tests that are given. You mentioned rapid antigen test and PCR test. Can you talk a little bit about the details of the rapid antigen test that students will have, and what the accuracy level of that is, and kind of what the purpose of that is, and how it slows, or what we expect around slowing the transmission?
Right. So as I mentioned, we're concerned that a lot of children are not symptomatic. So any thing you read now about the number of positive cases in schools is an underestimate, right? Because we tend to only test people who have symptoms. So this will allow us to test on a frequent basis. Now, when you're talking about testing frequently, then you have to balance on certain things like the logistics. How do you do a few hundred kids or staff at once? And so what we chose to do was we went with the antigen test because it allows us to get a result very quickly. And it is, as I mentioned, the swab that's used, the particular company that we're using, which is the Abbott Binax test, it does not require us. I mean, some of them do require that skinny swab that goes far back. So we feel that in terms of tolerance for students as well as staff, it's better tolerated. There are some trade-offs though. So compared to the PCR test, which is considered the gold standard test, the antigen test is less sensitive and also has some false positive, greater tendency for false positive. However, in terms of the infectious time period that we're looking at, the performance of this test really is not much different than the PCR test. So the PCR test might turn positive like half a day before the antigen test turns positive. The PCR test will continue to test positive for weeks after the person gets better, whereas the antigen test comes to negative more quickly. But both of these cover the time period where people are infectious. So in terms of what we're trying to do here, it works out really well for us. We will, and also both of them work very well in the infectious time period of the 5 to 10 day period. So we will catch people either on one end or the other end of that 5 to 10 day window of infectiousness. If someone does test positive, they will get a PCR test that same day. And so that's the advantage, right? That the PCR will take, often 2 days or sometimes 3 days to come back. This way we know right away, there's no delay, whether if the person is negative, then we're okay. If it's positive, then immediately we will do a PCR test to confirm. If it's a false positive, we will know within 2 days or so. And if the child is being, or the staff member is being quarantined, they can get back to school quickly. So we really try to balance the performance of the test here.
Great,
Thank you very much. Go ahead, John.
So next, we'll kind of get into some of the testing process questions that we received.
Mm-hmm.
We have a lot of questions around the idea of the participation level needed for the pilot to be considered valid.
Mm-hmm.
So if we have a high opt-out rate, what would be the threshold for the pilot being considered valid?
So I really would encourage everyone to participate, and as close as we can get to 90, 100%, the happier I'll be. Let me just kind of talk about the general ranges. So if we, for example, had about 25% participation rate, I would not be real happy with this, and because in some research trials, we might have that low a sampling rate, but it's a very systematic, right? So we don't know if, for example, a certain socioeconomic group or certain racial ethnic group opted out, if we're down at 25%. I would say we probably need a minimum of 2/3 to 3/4 of the students to participate. There are a couple of reasons. One is that, as I mentioned, there's a lot of impaired conversation going on. The more participation we get, the better information we will have, right? So is it true that only a small percentage of kids are coming to school infected, or is a high number of them coming to school infected and they were just asymptomatic and we never tested them? And then there are kind of two other aspects I would encourage every parent to consider. So I'm not sure which camp people fall into, whether they're the ones who are very concerned about their kids not being in school and they want the kids to be in school. Well, we're in a situation where if we don't do the testing, again, we're going to have to do a compromise to say one concern is more important than the other, right? I think everyone's kind of giving up a little bit. So those who really want their kids in school, we would encourage you to get, sign the consent, get as close to 100% participation as possible. Similarly, for the people who are concerned about safety and health and are saying we shouldn't have our kids in school, right? Again, we don't want to make an empiric decision. We would encourage those people, whether they're staff or parents of students, to participate as close to 100% as possible. We're realistically only talking about doing this for a few weeks until the holiday break. The more information we get, the more informed we will be. So for example, if we are indeed finding there are very few positive kids coming to school, even with this high rate of community infection, then we would feel better about going into January, maybe without doing the testing or with a different form of testing, right? So again, as close as we can get to 90, 100%, I would be ecstatic. I would say at least 2/3 to 3/4 would tell me that we've got a majority of the kids and that we've kind of evened out whatever random variations there were.
Thank you, Dr. Chen. I'll take the next one. And before I ask the question, I would just add that we've been fortunate to meet twice a week with your staff, and that has been very insightful for us as we've been able to get questions answered along the way. Here is a question that was answered today. And so Dr. Chen, whether you take it or Dale or Jennifer takes it, either way, there's some concern, and you mentioned the shorter swabs, but there's some concern, especially for younger kids. Does the testing hurt students? And I know both Dale and Morgan shared today about some of their experiences early on. So I would put that question out to all three of you, knowing that some of the information that was shared this afternoon might be very helpful for folks to hear again.
So Dale or Jennifer, you want to pipe up on that?
So I can say what I've seen here. I wasn't on that call, so I'm not sure exactly what Morgan said. But we've had lots of high schoolers come through because we had high school athletes get tested over the last 2 days, and you wouldn't even know that they were getting tested. They were just going on through, everything was fine. Same with the staff. The kids were mostly fine. They might kind of squirm a little bit, but that was as far as it went. But nobody was upset. There was no crying. And it was very, very quick. So I think it went very well.
Great. Thank you, Jennifer. Yeah, I mean, it's a cotton swab. It is, it's actually less irritating than like a throat swab where people might gag. So hopefully, I mean, our expectation is that everyone will tolerate this very well.
And Dale, I think you indicated some things this afternoon and were able to take a video. Are you able to share a little bit about that?
The video I had was from White River. Let me dig that up and come back to me, and I can show it to you if you'd like me to show it.
Well, and I think we're going to try to post it, but it just
Okay.
You mentioned that some of the kids actually thought it was funny. And
Yeah, that's watching that they sort of kind of tickled, and the folks administering the tests were really good with the kids, and you see it that it's just twirling the swab just like 5 times in each nostril, and it was fun to see the kids, just kind of react like it was tickling them rather than something intrusive. So yeah, when you guys post that video, you'll see how those kids reacted. It was nice.
Thank you.
Thank you. One of the questions was that the Institute of Disease Management came out recently with a widely read report. And the question was, in what way, if at all, did that report inform or change this pilot?
So I think I know which one they're talking about. IDM puts out lots of report. We're very fortunate to have them here in our backyard. They put out a report a few weeks ago, just when we had announced that we were going to be doing this pilot. And what they said in there was the vast majority of I shouldn't say vast, but the majority of the protection that they would expect is from the precautions that schools are already taking, right? The distancing, the 6 feet apart, the masks, bring kids back in cohorts and hybrid model and so on. And basically what they were saying is, that's the first thing you really want to do, and that you shouldn't be thinking that testing is just going to protect you without the other measures. And then they did some modeling about how much additional protection it would be with the testing. The challenge is that there's no standard testing procedure right now. Also, their modeling was done when our 14-day total case rate was much lower. It was modeled at 75 per 100,000. We are at like 300, hang on, let me just glance here, 383. So, I think it's a very useful report to read. I encourage people to take a look at that, as well as some of the other reports. It definitely supports the idea of why, we're so fortunate here in Washington State to have guidance that, staff and kids wear masks and that they're 6 feet apart and so on and so forth. I think you may be aware, I just read a report yesterday looking at Georgia, where school districts are so different in whether they even require masks or not. But the fact that this state has been very proactive in setting statewide guidelines for mask use, as well as the LNI came out with very specific school guidance, acknowledging that school employees do all kinds of things. It's not just teachers, right? We've got all kinds of staff supporting the education. And then even for education, we've got regular classrooms all the way to some children who are physically and developmentally disabled and are not able to maintain their secretions and wear a mask, because of their disability. So this state's been, I think, very fortunate in having a lot of that guidance. But we did look at that report. We are actually getting real life information. I think IDM's really great for helping us model and predict. We are as far as we know, the first county in the states that's going to be doing this. And as I mentioned, Department of Health is very anxious to see how this works and what we're going to find.
Thank you.
And Dr. Chen, again, and if you want to involve your staff on this one, that's great as well. There are some questions around who will be conducting the staffing. The PowerPoint, the slide presentation gave a schematic of what it might look like.
Mm-hmm.
Can you share a little bit, or others share a little bit about who are these people when our children and our staff walk in the door of that gym or that commons or lunchroom? Who will be doing the swabbing and the testing, and what does that all look like?
Yeah, I'm going to turn this over to Jennifer. It's a whole village that's running this. Great partnership that's coming together on this. Jennifer?
Yeah, so it's a little bit of column A, a little bit of column B. So we certainly have staff for the health department. We also have some contracted staff that Pierce County's Department of Emergency Management has procured for us. And then also some of the school districts are providing some nurses as well to not only supplement our work, but then to train to see how we can continue this beyond that holiday break.
Thank you.
Another question regarding the testing, the consent form that's on your website. And we want to remind everyone that that is on your, that there is a website for this pilot, and the consent form for both staff, adults and students is on that. The consent form states that I understand the test purpose, procedure, possible benefits, and risks. What risks should I be concerned about?
So in terms of physical harm, there's really not much. I mean, you know, we talked about the collection of the swab, right? In terms of other risks, you heard me talk about earlier that any test, whether it's the COVID test or even a pregnancy test or, you know, any kind of blood test, they all have some false positive, false negatives. You know, we do know that sometimes people get very concerned when they're told they might be positive for a condition. So they might create some risk, you know, stress there while we do the confirmatory test. And any test can have false negatives. So it is certainly possible we will miss something. But I want to emphasize that what we're actually providing here is an extra layer of protection, extra layer of mitigation. You know, we're not empirically assuming that that people are showing up fine at school and that, you know, that they're not transmitting, right? That because there could be so many asymptomatic people, this allows us to catch some of that, monitor that, step in quickly. If we are more targeted in how we isolate and quarantine, then there's less disruption for other classes. So as I said, the physical risk, I think are minimal. There may be some stress from the testing. You heard from Jennifer in terms of the process that, you know, the students seem to tolerate it well, and we know adults tolerate it well. So
Thank you.
Thank you. I'll take the next question, and we have a whole category here called contact tracing.
mm-hmm.
It was probably not a term that we used that frequently until COVID came around, but boy, is it popular now. I'll just kind of paraphrase and put some of these questions into one question. Should a student test positive on the rapid antigen test, Dr. Chen, you indicated that they would be isolated, and at that time they would take the PCR test. Following that PCR test, what do the interventions look like going forward there? What is contact tracing, and what is the definition of a close contact?
So case investigation contact tracing, as I mentioned earlier, is a key public health strategy. And this is, you know, how like diseases like smallpox, Ebola, right? Many of these illnesses, and even more mundane diseases like sexually transmitted diseases, HIV, and tuberculosis, right? It's very important for us to break that chain of transmission. So if someone tests positive in this, because we know there can be false positives with the antigen, they will be tested with the PCR test that same day. And as I said, just logistically, you know, technically it often can be done in a day, but realistically we say about 2 days, sometimes 3 days for us to get a result. During that time, they will isolate, and we will be trying to figure out who came in close contact with them. Now, in elementary grades where there is you know, the kids are in one classroom, it's not like high school where they may be moving between different classes, but in elementary grades where they're in one classroom and they often have seating assignments, that makes it a little bit easier for us because we know who's been, this general rule, we use 6 feet, 15 minutes. If over the course of the day someone's within 6 feet for 15 minutes or more, then they're considered close contact. So you can imagine if you've got a larger classroom, then the kids who are not within 6 feet and they're not mingling because they're not, say, participating in any kind of group activity, which gets them closer to 6 feet, then that allows us to selectively quarantine within a classroom. And certainly, especially now with all the you know, the size restrictions, the hybrid classrooms, then you could imagine, you know, kind of worst case scenario, you might quarantine, you know, like the Monday, Wednesday group, but the Tuesday, Thursday group could still continue to come in, right? whatever your schedule is on that. But it is really important also, whether it's in the school testing or just out in the community, if you're contacted by someone from the health department, that you cooperate with them. Of course, we will never ask you, your bank information, social security, beware, there may be scammers out there, but it is really important that if the health department contacts you and says you've been identified, as someone who may have been infected, that you cooperate with that, because we really need to try to nip the infection before it gets too far.
But
Thank
just
you.
to follow up on that, just to make sure the contact tracing is done by the health department?
So right now, the health department's still doing it. At the huge number of cases we're seeing statewide, many other counties are going to some form of modified case investigation contact tracing. In some situations, they are passing it off to the schools or to the employers, like if it's a business. Fortunately for us, we projected basically a 10 times projection from the spring. We have exceeded that, but we're still doing okay. And sometimes with businesses and hospitals where we're doing investigation, their human resources will want to do it because they're the ones who have the contact information for all the employees who work in a certain area. So we collaborate with, in your case, it'll be with your school and the administration at your school on that.
Thank you.
Thank you. Dr. Chen, there's a lot of questions about voluntary versus mandatory. Excuse me. And as we think about that voluntary versus mandatory piece, can you just share a little bit about the health department's philosophy and where we are on that voluntary versus mandatory component?
Yeah, I think there's several aspects of it. In some ways, I think it's kind of like testing. I'm sorry, it's like voting, right? I mean, it's like every vote counts, and we've seen that in some, right here in our county this past election, where some elections were, won by very narrow margins. But then when you think about other years when there weren't as much interest in the elections and people were not voting, right? I mean, there's some people who probably woke up the day after and realized that they made a mistake. And here we've got a time-limited pilot that we're going to do first. I really encourage encourage people to participate at the highest level possible. If nothing else, out of respect for the people who may have a different concern than them, right? It's, we prefer not to have one group say, well, my concern's the most important, therefore the other groups have to compromise. Like, everyone's got to do a little bit of compromise here. Well, I shouldn't say compromise, because I don't, our goal is to get as many kids back in-person learning as possible in as safe a way as possible, and keeping the community safe as well, right? I mean, we've got quite widespread community spread right now. We don't want that spread getting into the schools, and we don't want any spread in the schools getting out into the community, exacerbating the situation there. So, really encourage people to lean into this, do this, certainly for themselves and their children and the students, but certainly for the other people who may have concerns different than theirs. So the closer we can get, right? As I said, if we get up close to 90% participation and we are finding the numbers are going one way or the other, that gives us much more confidence than if we had 25% and we don't know if this is just a fluke, right? So let's really encourage everyone to lean into it for the few weeks before the holiday break.
So to kind of pick up on that, the voluntary part, if we do have a student, and a lot of our students are very young that are attending in person, and they bring their consent form in, but they come into the area for testing and they say, I don't want to test, I don't feel comfortable. How would that be handled?
We don't believe in forcing people to do things against their will. I think everyone who has children or has worked with children know that sometimes they have fears, and often it can, they can be calmed down. And so, I'm going to turn it over to Jennifer in a second. about how they would handle that logistically. But this is something that, those of you who are in school and parents for that matter, that every day, right? I mean, well, in normal times, right? How often do the kids come home and say they hate their teacher or hate the person that's bullying them? They don't want to go back to school the next day, right? I mean, we always walk them through that tension and the anxiety they're feeling. But Jennifer, you want to address that?
Yeah, so I mean, in thinking about this, I think about my son who's almost 5, and when he goes and gets a shot, who knows how his mood is going to be. Sometimes he takes it, sometimes he's kicking and screaming. Where if a kid is upset, we're not going to swab them. They're just going to go back to class, and we can try again next week. Or if the parents decide that they don't want to have their kid tested because it's the child that doesn't want to do it, then that's fine, and we'll move on. And we'll learn from that, because this is a pilot, and we'll take that and move forward.
Thank you, Jennifer.
Yeah, and of course, parents, I mean, all parents know, right, that they have so much influence on their children in terms of how the children's perceive, the world around them. So you heard me talk about how important it is for everyone to lean in and encourage you to talk this up with your kids. Your children, what gets them stressed out, what reassures them. Encourage you to work the magic that you have on your kids.
Thank you. And just a reminder, these questions aren't from Dan and I. These are from our staff and community. And there were a lot of questions about, the anxiety of kids coming into the situation. So we appreciate that reassurance.
Yeah, thank you. And Jennifer, I don't know if you want to stay on for this one, but there were a number of questions about the data. Where does the data go? How much is the school staff involved in knowing the data versus what the county manages? And so maybe that just starts with when the test occurs, if there is a positive, how is the parent informed, and who else knows about that? So can you, Dr. Chen or Jennifer, share a little bit about the data processing and maybe big picture as well as just localized in terms of what happens on that particular day when we're testing?
So let me have Jennifer start with that, and I'll fill in, anything that needs to be filled in.
So what happens when someone tests positive? Each school will have a school point of contact. We will notify the school point of contact that there has been a positive in the antigen test. Then that school point of contact will go to the classroom and bring back the student or the teacher to be tested for that PCR test. Then we are going to assume that is a positive while we wait for that PCR result, and the school will have to contact the parents to come pick up the child. The school, like with any other test, even if it wasn't part of our testing program, they would conduct their own internal investigation, maybe try to figure out who is a close contact, who's in that classroom, or who does that kid play with at lunch or something like that. The health department will use that line list of names to then contact the parents that those children may have been exposed to COVID. We share the information within the health department just for that investigation, and then we report it to the state health department. And we share information in these legal ways for lots of other diseases that have a lot of stigma associated with them, and people's privacy is like utmost when we're dealing with things like this.
Yeah, thank you, Jennifer. And Jennifer is absolutely correct. I mean, we handle very confidential information all the time. We are required by law to investigate these infectious disease cases, whether it's sexually transmitted disease, pertussis, measles, tuberculosis, HIV. There are laws that govern how we handle that information, who we share it with. Schools do as well, right? I mean, schools have a lot of confidential information about students' disabilities or their learning plans. And also if, for example, there were behavioral health issues or substance abuse or child abuse, whatever. But there are laws that govern how we handle that information. It is not made public, and we respect the importance of that staying as confidential as possible.
Thank you.
Thank you.
So when you were presenting the slides, you mentioned that you said weekly testing seemed to be a good fit for this program. We had several questions that or comments that kind of got at, well, wouldn't it be better to do more frequent than weekly tests? Can you talk to that?
Yeah, this is something we had long conversations with Department of Health about. I think they originally were thinking about doing every 2 weeks. We originally were thinking twice a week. The sheer logistics of doing testing twice a week is pretty immense. And so that was one of the issues. Another issue was, I mentioned to you that the really key time period, so counting from the time someone gets infected, there's this key time window from 5 days to 10 days when they're infected and they have high viral loads and they're are infectious to other people. Okay, so it turns out that our tests work really well in that window, and if you think about the 5 to 10 day window, if we're testing on a weekly basis on a 7-day time frame, we will catch them on one end or the other. Okay, so we felt this was a good balance between testing often enough and not missing anything, right? As well as the logistics, and it is disruptive to, especially now. Normally when we're not in COVID, say we're doing a flu shot clinic at a school, boy, you just bring the whole class down, have them line up and get their shots in their back. Right now, because the classes are split between smaller groups, and you're in hybrid and so on and so forth, and certainly for those in the higher needs, they're in groups of 5 or so, right? That it just logistically very challenging to try to do more than once a week.
Thank you.
So the next test is about if someone was to test positive, how do they get back to school? And so let's take this first of all from the standpoint of a positive test. If an individual, whether that's a student or a staff member, were to test positive on the antigen test and that was verified by the PCR test, at what point would that individual be safe to return to school? There's some question about how many negative tests do I need to have. Can you share with us, Dr. Chen, dispel any of those myths and share with us what the ticket back in would look like?
Yeah, so it is not recommended for people to get repeat testing to show they're negative. The PCR test, as I mentioned, can stay positive for a very long period of time afterwards. So right now the guidance, and this is pretty standardized guidance now from CDC, Department of Health, and everyone else, about when people can return, and it's based on when you got infected, or if you don't know that, when your symptoms began or when your positive test is. But the idea is, we want to get people back as soon as we can, and it depends on how many days after fever, or when they first started having symptoms or had a first positive test. So no more than 14 days, right? I mean, and that's 14 days. The 14 days typically is for people who are quarantining, people who are sick, because it will be how many days after they last had a fever or they first started having symptoms.
And is it the health department, or could it be a person's physician that provides that advice and those recommendations? Where does that come from? If I'm an individual that tested positive, who's gonna tell me when I have the green light to return?
Yeah, so typically, like in this situation, because you will be tested, the student or the staff member will be tested in school through this partnership with the health department, emergency management. We will be managing that. Now, certainly people have the prerogative if they want to go to their personal physician, although this is fairly standard, and it's nationally accepted guidance.
Thank you.
Thank you. If you mentioned this one and I missed it, I apologize. I have a question that asks, what is the specific rate of false positive and false negative with these antigen tests?
the number, there's sense that there are all these numbers that, you know, epidemiologists talk about with test behavior, how they behave. The number of false positives you get actually is correlated to some degree by what's going on in the community. There's something that we call the positive predictive value and the negative predictive value. In general, antigen tests have more false positives than the PCR tests. When you have very low disease spread in the community, more of the positives will be false positives. Okay, so it's a little bit complicated to answer that. However, it is well accepted that because there's this concern around the false positive, that if we test either with a different antigen test or with a PCR test, it will confirm whether it is positive or not. So we've built a backstop into this. We're not just going to tell people go home, stay home for 10, 14 days, that we're actually going to check and make sure it really is positive. And if it is a false positive, then, you know, after 2 days, whenever we get the results back, the person will be back at work or in school.
Thank you, Dr. Chen. This is very informative. I'm gonna circle back to the close contact. If someone has been identified as a close contact, and what would they need to do to return to work if they were an employee, or to return to school if they were a student? So again, a colleague or a classmate or somebody has tested positive and you've been identified as a close contact, what is the pathway to return to school?
Yeah, so in general, I wouldn't worry about it until you get contacted by the health department, right? I mean, that's part of what they're doing is our staff will be trying to determine what degree of exposure there is. It's one thing if there's a child who's sitting in a classroom, you know, just under 6 feet away, and the kids are all in, you know, individual desks, and they're not, you know, climbing on each other or you know, playing with each other, right? Very different than someone who, say, is taking care of a developmentally disabled student who can't control his or her secretions and is having to wear, you know, the full PPE to take care of that person. So our staff will be assessing what the risk is to the person, and you know, it will be if the person's not exhibiting symptoms, then there will be some combination of quarantine, right, that they need to stay at home. So while they're incubating the possible infection, that they're not spreading it, because people can shed the virus before they're symptomatic. And then they will may need to get tested to see whether they're positive or not. But this, you know, our staff will go over that with the person when they're, if they've been exposed or if they're positive.
Thank you.
So can you talk a little bit more about the pilot program moving to a more ongoing program? So you've talked about it ending in December, and then you would evaluate the results and then use that to consider a more ongoing program in 2021. Can you talk more about what you'd be looking for from the pilot results that would result in wanting to move forward with an ongoing program?
Right. So, you know, one of the challenges that we have right now is that this is being funded through CARES money, and unfortunately, Congress has hit some kind of gridlock, and you know, they've not been able to move forward to either extend the time frame which we can expend the money, or authorize an additional relief bill. So right now, what we have done is we have purchased as many testing equipment kits as we can. So that we will have kits. The staffing that you heard Jennifer talk about, a lot of that's being paid by CARES funding. So we're hopeful that if nothing else, that Congress can at least reach agreement to allow us to continue to use any unspent funds past January. But then hopefully, you know, now that elections are over and that, you know, all this politicking is dialed down to a lower level, that they will be able to pass another significant relief bill. So we cannot guarantee what's going to happen after January 1st. We're hopeful that the information that we can gather now before the end of this, before the holiday break, will give us a lot of information about how to start it back up. Our intention is to continue it. We just need to make sure we've got the resources to be able to do it.
Thank you.
So here's another question about looking forward, and forgive me if it ventures a little bit off of the testing topic. There was a question in here, and we'd love to get your insight. As we continue to hear about vaccines being developed, Dr. Chen, what are your thoughts about as those continue to roll out? What do you foresee as the impact on Pierce County and how that might affect us with the vaccine rollouts that we're seeing?
Yeah, so if you think about the number of people in Pierce County who've actually been infected, I mean, even though our cumulative case count is around 15,000 people, remember, we've got 900,000 people here in Pierce County. So that's just a tiny fraction. And I think we've seen in other countries that trying to achieve community immunity through infection does not work. The countries that try to do that have some of the highest death rates from COVID-19. So what's going to help us in the short term is everyone needs to mask, practice the social distancing. I know Thanksgiving's coming up, and unfortunately it means not having parties and having family over. That's what we need to do in the short term until we can get a vaccine. The challenge is, I mean, you just in the past week, you've heard 3 companies announce really good results on their vaccine. One of them at least has applied to get emergency authorization to start applying the vaccine. I'm not sure how long that will take. But then if you think about how many people in the world are going to need this vaccine, you will understand that there's going to be short supplies in the beginning. The federal government, the State Department of Health, and we have all been planning, and there will, once the vaccine is released, it's going to be a huge logistical issue. You think about the 900,000 people, we're probably going to need to get at least 60%, preferably 75% or more of the 900,000 people immunized. That will mean prioritization. That means first responders, doctors, are going to get prioritized first, and then we're going to be moving to those with risk factors, those based on their age or their health conditions. But it's going to be a slow rollout. Don't be surprised if this time next year we're still vaccinating. We believe that there probably will be significant volumes of vaccine available probably by the spring. Of course, we're doing the highest risk, the top priority first, and then the spring there'll be more available, but we will continue to vaccinate. We'll probably still be vaccinating this time next year.
Thank you.
So can you clarify a little bit about the science around community spread from asymptomatic children to adults? There are concerns that our community spread may be mostly asymptomatic and wouldn't be caught by the weekly tests.
Right, so the reason we're doing the weekly testing is that it doesn't matter whether the kids are symptomatic or asymptomatic. We're going, or the staff for that matter, that we're going to test them, right? And so there's the symptomatic versus asymptomatic piece, but also there the fact, like with any other illness, people will often shed virus before they develop symptoms. Okay, so but again, I mentioned the performance of this test in that 5 to 10 day window, that because we're going to be testing once a week, we will pick them up on one end or the other. We'll either pick them up just as they're getting sick or pick them up on the other end where they are kind of getting towards the end of their infectious period. They may not be completely done with their infection, but again, what we are concerned about, and this is a public health perspective, right? It's a little different from the medical perspective. The public health perspective is we're most concerned about controlling the infection. So the 5 to 10 day window is when the viral load is the highest and they are shedding the most and most likely to get other people infected. So if we can catch them on one end or the other end of that 5 to 10 day window, we can get them isolated and their contacts quarantined, kind of try to break that chain of transmission, stop it from spreading. But again, as you said, lots of conversation around how asymptomatic are the kids, much more so than adults, okay? And, we want to pick them up by doing this testing. We also want to protect staff and other students by doing the testing. That's why we see this really as a win-win-win, right? It helps, it allows us to have the kids in school, allows us to say we're actively looking for infections to protect the health of the kids, helping us understand how much they're spreading it. And then because we can get on top of the infections quicker, then that's helping protect the whole community by not allowing it to spread more widely.
Thank you.
Dr. Chen, I don't know if I can speak for my colleague, Mr. Hellwich. We've just, we continue to look down at the paperwork and try to see if there's other questions that have been asked that we can put in front of you to answer. This has been very informative. John, I'm kind of turning it back over to you, or Sara Hoover, who's on here. Is there anything, Sara, that you can share or questions you have just around logistics as we get forward, as we get ready to move forward? Not so much with the testing on the 29th, because that will be conducted not necessarily through us, but more so as we move forward with the school level testing starting on the 30th.
No, I think Morgan and Jennifer are going to be working with us tomorrow to finalize the number of stations per site, kind of define what we will need for equipment, tables, etc. And we will have all that finalized tomorrow, I hope, and we can then release that information out to our building principals.
Thanks, and I just say I believe we're scheduled for a community message out on Saturday with some of the final details heading into our Sunday mobile vans and then our Monday kickoff for our weekly testing.
John or Sara, do you have anything else from a district standpoint?
No, I think just a big thank you to Dr. Chen for being here and answering all these questions tonight.
Yeah, Dr. Chen, I guess the one question that I would finish with that's kind of a large overarching question is what would be the indicators if this pilot program was successful that you would be looking for? What would constitute this being a success?
Well, I think it'd be a success if we address all three of those concerns, right? That we can get the kids back in school, learning in person, at the same time documenting that we're really not seeing that many positive cases, or if we're seeing positive cases, that they're not spreading, right? That right now there's so much community spread that it's certainly possible someone picked this up at home or wherever, but as long as they're not spreading it to other people, we're keeping the school environment safe, and that we can get those people the care they need, right? And then, so to me, that's the win-win-win, right? That we can get the kids back in school, they can learn. Schools do so much more than education. I mean, you know that, right? I mean, they connect people to social services, they feed kids. I've heard from parents whose children are developmentally disabled, or even have children on the autism spectrum, and they just are having such a hard time managing their kids, right? That if we can get them back in school in a safe way so that everyone feels good about it and people are not worrying that they're going to school or they're sending their kid to school and risking their kids getting sick or themselves getting sick. I think, getting everyone reassured and showing that we can do this without making, increasing the spread in the community. That's the win-win-win. And I'm really appreciate Peninsula School District and our other school districts and our other partners who've been working with us on this. We'll find out in a few weeks whether this is going to work or not. But I think it gives me hope. On the one hand, I'm looking at all these numbers going up every day, but it gives me hope that we might have a path forward, at least for this community.
Thank you very much. I would just like to add, and maybe Dale or Jennifer would chime in on this, or Dr. Chen, maybe you have the answer. If people would like more information, and I know we were displaying some of the Tacoma-Pierce County Health Department website yesterday, whether it's you or Dale or Jennifer, where might people go for more information, and can we provide them with a little bit of guidance before we sign off this afternoon?
Dan, this is Dale.
Yes.
We do have the website, which I think you probably shared, which got a pretty extensive FAQ and some other information. We'll be adding to the FAQ as we go along. It's kind of a living document, so it's not static. As we get questions from your district and other districts, we'll add more information there. You can also, Amy, from your staff, we meet weekly with things, and so anything she can bring to us with additional questions and stuff that might be helpful to your district, she could reach out to me and we'll get the answers to them. So that's a couple of ways.
Thank you.
Thank you. And for the 174 folks who are still on, if there are more specific questions, Mr. Hellwich indicated earlier that we'll be sending out some staff information as well as some community information to address those, the questions that are particular to those two constituencies. You can also email Mr. Hellwich, myself, or Ms. Gordon. If we don't have the answers, we will forward the email on and find people that do, that can help you with some of those answers. We want to be as informative as possible, and circling back to what Dr. Chen had said earlier, we want people to make an informed decision. And when we look at this as a district, we really don't see a lot of drawbacks to providing consent to testing. And it just helps us be more healthy as a school district in our school buildings, but I think there's also implications for our community. If we do have people who are positive and we're able to intervene and isolate and quarantine, that will not only reduce the transmission in our school buildings, but I would assume in our community as well. John, Sarah, anything else from the district level?
In addition to Dr. Chen, thank you to Jennifer and Dale and your whole team for your work coming out with our site visits and all of your meetings with us. Much appreciated.
Well, thank you.
And then finally, thank you, John. We'd also like to acknowledge and thank Tanya Beatty. Tanya is the administrative assistant to Dr. Jarvis, and she's helped coordinate this. Dale has mentioned Amy Gordon, our Director of Communications. Amy has played a large role in this and is very busy these days helping us get information out and trying to make sure we have accurate information that we push out to staff. And then also Chris Hagel from our Department of Learning and Innovation. Chris helped us set up this webinar to make sure as many people who wanted to log on could access the information. John, you had mentioned a little bit earlier posting of this meeting. Can you just kind of cover that a little bit so folks will know where they can go to check back in should they want to review the meeting later on?
Yeah, so on our reopening page, there's information about the pilot, and this recording will be posted along with links to the Tacoma-Pierce County Health Department site, which has the consent forms, which will have a lot of the information that Dr. Chen shared. So go to our website and to our reopening site.
Thank you again, Dr. Chen, Jennifer and Dale, and we appreciate coming on and helping us, and we will we'll take you up on the invitation to continue to direct questions towards you so you can very much help us with the technical side of things.
Okay, great. Thank you.
Finally, thank you to everyone who joined us this evening. We appreciate you jumping on and you're seeking information. Thank you and have a great Thanksgiving. Happy Thanksgiving.